I'm Dr. Suresh Ramalingam, Professor of Hematology and Medical Oncology and Deputy Director of the Winship Cancer Institute of Emory University in Atlanta. I'm a thoracic oncologist, and I focus on the treatment of lung cancer and research on lung cancer. The first step, of course, is to make sure we detect EGFR mutations. So any patient with newly diagnosed non-squamous non-small cell lung cancer with metastatic disease should undergo molecular testing. And there is increasing evidence now that using an NGS or next-gen sequencing approach is preferable because there are so many potential targets that have FDA-approved treatment options. Having said that, once you know that a patient has EGFR mutation, we also want to know what specific type of mutation the patient has. We know that nearly 85% of the EGFR mutations are exon 19 or exon 21. So these are the exon 19 and 21 are referred to as the most common sensitizing mutation. For these patients, the first-line treatment now is osimertinib. Now, certainly there are multiple EGFR inhibitors approved in this setting, including first-generation drugs, gefitinib, erlotinib, second-generation drugs like afatinib and dacomitinib. There's also a combination that's been approved in the form of necitumumab and erlotinib recently. Osimertinib is a third-generation EGFR inhibitor. It has been compared head-to-head with either erlotinib or gefitinib in the FLORA trial. There was an improvement in progression-free survival and overall survival when patients received osimertinib. Osimertinib was also associated with substantial CNS activity and has a safety profile that allows it to be used in patients for even years. For all these reasons, osimertinib has emerged as the preferred frontline therapy for metastatic EGFR mutated non-small cell lung cancer patients. The NCCN guidelines recommend osimertinib as the preferred frontline therapy as well. The approved dose is 80 milligrams per day. And once patients are on it, the more common adverse events include grade 1 or 2 skin rash or GI toxicities, but most of them are mild and usually in the initial part. So this is the first-line approach most physicians use in the United States. When patients progress on osimertinib, presently the standard of care is systemic chemotherapy. There are also emerging options based on understanding the specific resistance mechanisms that are in play. Now, when we transition from osimertinib to second-line therapy, it's important to keep in mind that there are some patients where the progression is relatively slow. And for those patients, we continue beyond progression, the treatment, and sometimes consider the use of radiation or SBRT to oligometastatic sites of disease. When the patient clearly has symptomatic progression and radiographically has multiple areas, that's when we make the switch from first-line to second-line therapy. The good news is with this sort of a treatment program, the median overall survival for an EGFR mutated patient now is well over 3 years. While that is still far short of what we want for our patients, it's a substantial progress compared to what we had in our hand a few years ago. So this provides the springboard to develop even more effective combination approaches.